Well, it depends if we plan on graduating on time in 2014 or not. Okay. The management of patients with bronchial asthma is outlined in what is known as the EPR3. This is now the third, actually I think EPR4 maybe even. But basically it's an expert panel report. So they got a bunch of experts on asthma together, went through the literature, and periodically they've gone and updated it based upon new evidence that has come out. But it's a division of the National Heart, Lung, and Blood Institute, which means that your tax dollars are supporting it. Thank you very much. The National Asthma Education Program, Education and Prevention Program, was basically what we're looking at. And this was novel because up until this time, there wasn't a consensus on how to best manage asthma. And they're using basically any kind of literature and diagnostic tests and techniques that they can to come up with a recommendation. You can download it. I think I have a link to it on my site. Do not print it out. It's 487 pages long. Unless you really don't like your printer, there's no reason. You can. It's in PDF format. You can take a look at it there. And there really is four cornerstones that asthma management focuses on. The first one is using some kind of objective measure of lung function to look for severity and to monitor the course of therapy. Something objective as opposed to subjective, although to some extent, based upon certain age, I can't do a peak flow or an FEV1 on a 6-month-old. I kind of have to use some subjective evaluation of it. But wanting to be able to identify whether or not the therapy that is being prescribed is working. Second component of it has to do with environmental control. So looking at those things that trigger asthma attacks, trigger exacerbations, and being able to identify them. You can't manage the disease without figuring out why it's starting. Okay. Patient education is a cornerstone also, so that kind of makes it that there's a relationship that is established between the patient, the family, and the physician, and any other healthcare giver like us that would be involved there. And the fourth part has to do with pharmacologic therapy, because that's kind of the cornerstone for management of this. And the idea being to reverse and prevent airway inflammatory instances. Okay, so that's kind of what the goal is. With asthma, you should never see an ER. You should never be into the ER. It should be managed as an outpatient. Okay, that's what the goal is, anyways. The definition: it's a clinical syndrome characterized by inflammation on a chronic basis. Okay, so it's not something where I just have an acute bronchitis. This is something where I have chronic airway irritation. The bronchoconstriction, as we learned yesterday, is talking about occlusion of the airway secondary to bronchospasm, secretions, and inflammation. It usually is completely, or to a large extent, reversible as opposed to the airway resistance problems that occurred with COPD, which aren't always reversible to any extent. There's also that group of patients that we just kind of call hyperresponsiveness or twitchy airways. Even though they're not classic, they don't meet all the classical signs of asthma, they end up having hyperresponsiveness. There, in addition to the bronchoconstriction and inflammation, there is a increase in mucus production that they end up having, which can lead to infectious problems associated with that. And then finally, there's some airway remodeling there. And what I mean by that is that structurally, the airway, if left untreated, can end up with some chronic changes that will lead to lifelong problems. So this is one of the main reasons that we encourage parents to get on board with management of the asthma at an early age and being able to not have the problems with kids later on in life. The official definition, again, a chronic inflammatory disorder in which there's a lot of cellular activity with eosinophils and macrophages and neutrophils. The patient themselves, that inflammation leads to episodes of wheezing, breathlessness, chest tightness, cough, particularly at night or in the early morning, and they're usually associated with variable airflow obstruction that will respond to treatment. It's also an inflammatory process where there's bronchial hyperresponsiveness, and that's why you end up having the airways closing. And again, more recent evidence, this is where the airway remodeling comes in, because they end up having some fibrotic changes of some of those subbasement membrane tissues that are there. Okay. So, their focus should be around two different components. One is to reduce impairment, and one is to reduce risk. Reducing impairment means that we're going to treat the symptoms. Okay. The goal should be also that we're not using short-term beta agonists as a primary mechanism to treat. And that's a total reversal from the way asthma was managed 20 years ago. Okay. They should be able to maintain pulmonary function values that are near normal. And that means also that school, work, any kind of physical activity should have no impairment. There's no reason that a kid who has asthma cannot play soccer. And again, meeting patient and family expectations. So those are ways that the goal should be to reduce the amount of burden that asthma as a disease places on a patient and their family. It also should reduce the risk in the sense that they should prevent these exacerbations from happening. So the more we can reduce the time that a patient spends in the hospital, obviously the better off it is. Along with that, we talked about the loss of lung function. You don't want that to happen. That's that airway remodeling component. And any medication that we prescribe should have should be low risk in the process. And how do we know that this is working? We look at the severity as far as the intensity of the disease process. And it's measured by looking at how close they are to the plan that they're supposed to be placing on. And the control is to the degree to which those undesired things happen. And responsiveness talks about how easy it is to control it. So we talked about asthma having an impairment and a risk component, or the treatment of it, and that severity and control will look at how asthma affects their life in the case of impairment, and the risk as far as the risk of exacerbations. All right, one special type of asthma that we need to be aware of is something called status asthmaticus. And this is basically one that does not respond to conventional therapy. So if an asthmatic shows up in the ER and they're not responding to inhaled beta agonists, they're not responding to steroids, that's a sign that that asthma attack is in a special class. And the incidence of, it's not very common that it happens, but these are the patients who have asthma who end up on a ventilator, which is not a common entity, okay? And they often have some other comorbidities involved. Gastroesophageal reflux disease is a very common trigger for these folks. They have this micro aspiration of gastric contents, which then causes the airways to become inflamed and an asthmatic attack to be triggered. They often have allergic rhinitis and a seasonal effect from that. And there's an interesting side as far as psychiatric illness. A lot of times just change in moods can trigger an asthmatic attack. Roughly 10% of the that's not true. 12 million is not 10% of the population. But I think that number is probably a little bit higher even. But it is a very prevalent disease. And as I mentioned yesterday, we've gotten better drugs, but we've had more mortality from it. And whether that's behavioral involved or just due to training, I'm not sure. Higher incidence in blacks, higher incidence in populations that are economically deprived. Flint actually has one of the worst asthma mortality in children around. So, kind of an interesting aside. Leading cause of hospitalization and absenteeism from school for children. And I don't know what the cost is, but it's a lot. Two terms that we used to use, that the EPR3 does not use them, but if you see the terms extrinsic versus intrinsic, extrinsic was known as allergic or atopic asthma, and atopy is the genetic disposition to having a twitchy airway. Usually this is the ones that you end up seeing the IgE being released, and there's identifiable predisposing factors. So I know that I'm allergic to ragweed. I'm not, but assuming that I was, and I'm exposed to ragweed, or I know I'm allergic to cats, and I'm exposed to a cat, I develop an asthmatic attack. That's an extrinsic in nature. Yeah.
How about sports-induced asthma?
That'd be more along the lines of intrinsic.
Okay.
So exercise-induced asthma is not something where the trigger is an allergic reaction, as it is in extrinsic. It's just other things that cause the airways to become hyper-responsive. Yep. So again, these are the antibody antigen, and that antigen can be pretty much anything that are out there, even things in foods. And again, just going back in time, we know that that antigen causes the lymph to release IgE. That IgE then sensitizes a mast cell. Further exposure causes that mast cell to degranulate, and the release of all kind of nasty things that cause the inflammatory response to occur. When that inflammatory response occurs, they end up having smooth muscle constriction, dilation of the blood vessels, flooding the bronchial epithelium, and causing an increase in mucus production. So all the classical things that you would see in an inflammatory response, all because of those nasty things being released. So again, those chemical mediators, things like histamine, things like eosinophilic chemotactic factor of anaphylaxis, yeah, right. Neutrophils, leukotrienes, prostaglandins, nasty stuff. And that's what we end up saying they end up having. The response to these mediators can occur, they occur immediately, and there's an early asthmatic response. And then there's also a kind of a second kick that comes in 4 to 6 hours later, where the inflammatory response worsens in a lot of patients. That intrinsic or non-atopic asthma is often adult onset. Their IgE levels do not increase, so it's not because it's not an allergic reaction. Doesn't necessarily have to have a family history of allergy, and you can't tell the difference between the two of them because they both manifest the same way, and that's kind of why EPR3 doesn't really care. It just is another type of disease. So it could be caused by, like we said, exercise-induced. It can be caused by psychiatric issues, other stuff, but it's not allergic. That's the key part.
So is the status asthmaticus an intrinsic?
Status asthmaticus status asthmaticus is an asthma attack that's not responsive, and it can be by either.
So it could be either.
Oh yeah. But you can see some of the other things that are there: occupational exposure, smoking, aspirin.
It's funny you put all kinds smoking.
Good point. And the reason being is that there's a perception. Well, let me back up a second. The active ingredient in cannabis, THC, is a bronchodilator. But the downside is you have to smoke it, and the smoke is an irritant. So, catamenial. There's a type of pneumothorax called catamenial pneumothorax And there's an asthmatic attack that is associated with menses also. So sorry, ladies, but you get it. And pregnancy, same thing. Pregnancy can cause asthma, can worsen asthma, can improve asthma. I'm not sure what the hormonal responses there involved with that. Pardon me? Okay. Interesting. And again, it's just kind of showing the picture of all the intrinsic aspects. Again, they don't mention the terms. There's some thought that some of the responses that occur in asthma are why some drugs will work wonderfully with a group of patients and have no effect on other groups of patients. We'll find that leukotrienes inhibitors are there's some asthmatic patients respond well, others has no bearing. They believe that there may be some different phenotypes. So genetically, our genetic code may be built so that different medications respond to different people. And I think probably 50 years from now, we'll have drugs that are coded to our DNA, which I think is absolutely cool. Okay, asthma and COPD, they're both obstructive diseases. They both have hyperinflation and air trapping present. And that's about where the similarity ends. This one typically has both high inspiratory and expiratory area resistance, where COPD is primarily just on the expiratory phase. They generally do not have all the concomitant right side heart failure involved. And it's far more reversible. That's the important thing to bear in mind. Although COPD, again, looking back at that Venn diagram that we showed, can have overlap there. And this is just kind of showing the similarities between COPD and asthma. And when you start getting to severe asthma, that becomes very, very close to COPD as far as the inflammatory responses there.
Mark, I have a question about the T cells. Would a person who's infected with HIV or have AIDS be much more susceptible to asthma?
Not necessarily.
No?
I think it's a different, it's different T cells, because remember there's multiple types. And what goes on with AIDS, I think, is more the T helper cells. And these are a little bit different. So the anatomic alterations that we end up seeing, we talked about that subbasement membrane thickening, flooding from the inflammatory response. Eventually, if left untreated long-term wise, those basement membranes become fibrotic, which is why we encourage parents to get their kids on appropriate therapy. The smooth muscle actually hypertrophies and hyperplasia, meaning there's more of it and it's thicker. Okay. And then the mucus glands also become, both the goblet cells and the bronchial glands, there's more of them and they become bigger and produce more mucus in the process. And along with all of this, there's an increase in the vascularization, which then further promotes the fact that I can have more swelling present because I have more blood vessels there able to leak fluid out into the local area. Bronchospasm secondary to that smooth muscle becoming twitchy. And again, there's that acute and persistent inflammatory process. During the time an acute attack is happening, there's airway trapping and hyperinflation. And we talked about the long-term airway remodeling. Do you have this picture? It's a pretty cool one. So where management of asthma happens is really breaking this chain anywhere we can. Looking at the environmental factors that lead to the inflammatory process, doing something to avoid them, doing something to prevent the mast cell from degenerating and releasing all of those nasty things, looking at things to increase mobilization or to prevent the increase in mucus production, and managing the mucus production can end is another way that we end up looking at it. So we'll find there's multiple ways that we're going to come across trying to manage asthma. And this is a picture out of EPR3, and you can see all the different pathways that are there. And I have no idea what half of them mean, so we'll leave it at that. I think I'm going to stop here. I don't know why I have that in there.